Okay. Hey guys, this is Shavia. I'm on Chief Team this month, and we're presenting a case. The best team, and Sarah is our attending, so we are all very happy. We're presenting a case. The title is An Unsolved Mystery of Multi-System Disease. Yeah, let's get started. Woo! Yay. Do you want to move the slide for me? Okay. What? Okay, so case presentation. This is a 66-year-old female that came to the our ED, complaining of worsening right flank pain ever since she was started on this new medication called Agranox on October 8th. According to her daughter, patient was seen at Nash ED a few hours ago for abdominal pain and stroke-like symptoms that the daughter characterized as slumped over, not talking, not smiling, and having weakness. So patient got a CT head, and the CT head basically diagnosed it with a remote infarct or evolution of her old infarct. The daughter apparently signed her and the mom out AMA because the ED took too long to give her Pepcid for her abdominal pain, so they left. Apparently, the patient's weakness and like dysarthria and her stroke-like symptoms got worse after a few hours, and then they showed up at our ED. So that's how we got our patient, and then code stroke was called. Yeah. Okay, so this patient, interesting. I'm just going to go through this really quick because there's a ton of history. But basically, before 2018, her past medical history was basically her past surgical history. So just bilateral carpal tunnel release. She had an appendectomy 20 years ago. No history of miscarriages or stillbirth. This will be important as we move on. Okay. So in 2019, she had these like weird symptoms of like hearing loss and dizziness, and she went to the ENT doctor and audiology, and they couldn't really figure it out. So she ended up getting an MRI. Again, all of this history is from Care Everywhere, and it was just, you know, I don't know the very specifics of it, but this is like the generalized history. So anyway, she got an MRI done in 2018, which was negative. Then it seems like she was fine. And then in 2019, she started having these series of TIAs where, you know, she was having some confusion, word finding difficulties, memory problems. So in 2019, she went to the ED with these symptoms. CT head without contrast and MRI brain were negative. So anyways, they initiated a stroke workup. Echo at that time showed a normal EF. There was no interatrial shunt, although they did find a right ventricular systolic pressure of 35 to 40. What? Sorry.
I have to check the attendance. Keep going.
So anyways, yeah, that was her echo. So then she comes back in September of 2019 with the same TIA-like symptoms, and more, you know, stroke workup is initiated. CT head at that time was negative. However, during that admission, she had some chest pain, and they did a nuclear stress test, and it was abnormal. So they decided to cath her. And mind you, this lady didn't really have that many like risk factors for coronary artery disease. Like she didn't have diabetes, she did not have hyperlipidemia, she did not have hypertension. So, but the cardiologist decided to cath her. At that time, her left heart cath was normal, but the coronary angiography showed some coronary artery disease. So she got true drug-eluting stents in the mid-left circumflex artery and was started on DAPT for a year, so aspirin Plavix. Okay, so then that happened. Then fast forward to January of this year, started having like weird leg pains and bilateral lower extremity edema. They got a venous duplex. She did not have any DVTs. While all of this is brewing, she started having worsening renal function. By the way, this lady follows in Boyce Willis Clinic, so a lot of the history, again, is not, you know, I don't know the specifics, but anyways, I can only assume her renal function was worsening. She was sent to nephrology at Boyce Willis, and there the nephrologist made the decision to do renal biopsy for ACAN, CKD, and proteinuria. I do not know how much the proteinuria was. Okay. So the biopsy showed renal limited TMA, so thrombotic microangiopathy and ischemic glomerulopathy. So that's what the renal biopsy showed in September of 2020. Then she, on September 7th of this year, again comes with stroke-like symptoms. All of this is at UNC Nash, CT head MRI brain. Now she actually has evidence of a stroke. So acute to subacute infarct in the right corona radiata. Then, she goes back and again pops up with a stroke, and again in September 24th, same workup, which shows late acute infarct of the right frontal lobe, white matter. So that's when they started, they got the CT head and neck, which showed pretty significant right MCA, M1 and M2 stenosis, 80 to 90%, and also right-sided intracranial, extracranial ICS stenosis and left extracranial ICS stenosis of being 40 to 50%. Mind you, throughout these years from 2018 to 2020, multiple EKGs throughout the years have showed normal sinus rhythm. Social history, never used alcohol, cigarettes, illicit substances. She works as a TA, as a teacher's assistant, and was fully independent and functional until 11 months ago. Family history, father died of a blood clot at 72, mother had heart issues, not sure what the heart issues were, but mom died in her 50s, and our patient has 3 daughters and 3 sons. She does not know of any illnesses that the kids have. That's her history. Okay, continuing with the initial presentation, review of systems, basically anorexia, abdominal pain and weakness. We have her vitals here. Her blood pressure was soft, 102/50, heart rate 81, normal. She was afebrile, respirations were fine, saturating okay, BMI 24, kind of on the low side. Physical exam, like chronically ill looking lady, temporal wasting, no ulcers in the oral mucosa, doesn't have teeth. Cardiovascular exam, there's a systolic murmur in the left upper sternal border. Other than that, everything was fine. Lungs, pretty much okay, but some decreased lung sounds in the bases bilaterally. Abdomen, tender to palpation in the right upper quadrant with guarding. That's it. So neuro, so she had a left-sided facial droop, left-sided hemi-neglect, cranial nerves were okay. Left upper extremity had basically no strength. 3 plus to 5 proximally and 0 to 5 distally. So sorry, it did have strength. Decreased sensation on the left upper extremity was noted at that time. Right upper extremity was fine. And bilateral lower extremities 5 out of 5 in strength. But decreased sensation on left upper extremity and lower extremity. Her cannot speak today. Finger to nose was fine. MSK, no gross joint or bony abnormalities. Extremities, noted left upper extremity was limp. They did note that her hand was swollen and cold, and she had some bilateral lower extremity edema. Skin, otherwise, skin exam was normal, no rashes. They did notice that she was tan. Okay, so labs on presentation. We can pull up our chart for labs on admission if you guys are curious about which labs they did when we get to our differential diagnosis slide. But basically, she had thrombocytosis, leukocytosis. Her renal function was deranged. Her creatinine was 2.33 and BUN was 48. Her GFR was only 20. Her hepatic function was fine. Okay, guys, a lot of information, but pretty much lady with recurrent strokes and renal failure. What are the differential diagnoses? Okay. Adrian said lupus. Oh, sorry. Max said lupus. Okay, so hypercoagulable state. Yeah, and mind you, the renal biopsy showed TMA. That was, yeah, so that was interesting. thrombotic microangiopathy. No, well, like HUS, DIC, TTP, ITP, all of that stuff. Okay. Anything else, guys? Cryoglobulinemia. Okay. No hep C or anything like that, by the way. Okay. Anything else? Okay, sure, renal failure, ATN, okay. Okay, multiple myeloma, cool. Renal failure, yeah. I think calcium was fine. Anything else? Vasculitis, yep, okay, that makes sense. Okay, so really good differential diagnoses of renal failure and multiple strokes. But I mean, do you guys think they both are connected, or do you guys think she just has, like large artery atherosclerosis and is just throwing clots, and she did have pretty significant stenosis of the right ICA? Do you guys think it's connected? Seems from the differentials, you guys think it's connected. Yeah, exactly. 66. Okay, moving on for the sake of time. Okay, this is Saban, our fearless intern.
Thanks, Xavier. All right. So patient was admitted to ECU Dunmed with stroke-like symptoms. She had left-sided weakness, some slurring of speech, some element of mutism, had worsening flank pain, abdominal pain, and her high blood pressure was kind of soft on presentation as compared to her baseline blood pressure. And she was also taking lisinopril low dose at home. So a code stroke was called on her first post-admission day due to concerns of new left-sided weakness. Her last known normal time was unknown, and her NIH stroke score at that time was 16. So neurology came by. They ordered an urgent CT head and MRI. We showed right MCA, well-established infarct, and then stroke neurology, that dropped their note and recommendations. As part of the stroke workup, MRI head and neck was ordered, which did not show any new changes as compared to the CTA head and neck that was done in September, almost 4 weeks ago. And radiologists, based on the imaging, dropped their differential diagnosis. There were atherosclerotic change versus chronic thromboembolism versus Moya-Moya phenomena. Does anyone know what Moya-Moya phenomena is? Yeah, good. So it's basically a proliferative disorder of small vasculature in the brain. The word moya-moya comes from the Japanese language. It means like puff of the smoke. Yeah. So basically, it's a congenital versus sporadic disease, and it's like a radiological diagnosis. Patient can have recurrent strokes. For abdominal pain, patient also had like CT abdomen and pelvis. We did not show any new acute abdominal pathology, but uppercuts did show some bilateral basal opacities suggestive of consolidation versus atelectasis. So this is the first MRI. This is a DWI image of the MRI, and you can see the a well-established right MCA infarct there. Rest of the anatomy is intact. So neurosurgery was consulted. They did not do any intervention because stroke was well established and probably the subacute to late onset of the stroke. So they recommended to continue with Agranex. Remember, like patient was on Plavix initially because she had DES done for coronaries, but due to suspected atypical HUS, Plavix was taken out of her medications, and she was switched to Agranex. And she could not tolerate statin, so she was switched to ZTR for hyperlipidemia. EKG on admission showed normal sinus rhythm. Hemoglobin A1C was 4.9, LDL was only 34, and HDL was 24, despite being on ZTR. A TTE was repeated again. We showed normal EF 60 to 65%. RV was mildly dilated, moderate TR, and right ventricular systolic pressure was elevated moderately in the range of 65 to 70 millimeter of mercury. To our surprise, bubble study did show an interatrial shunt. So that was a new finding as compared to the echo that was done in September. So keeping in mind the whole picture of the patient, stroke, AKI, HEMONC, and ENA were consulting at the same time, and patient was like already undergoing workup for atypical HUS, and she had a renal biopsy done in September, which showed TMA. So, I mean, in terms of TMA, atypical HUS was the only microangiopathy that was fitting in the picture. HEMONC reviewed her records, labs done in the past, and they were like, there's no evidence of hemolysis in any of the dose, so TMA is unlikely.
And there was thrombocytosis, not thrombocytosis.
Yeah, thanks. And patient had normal complement levels, Coombs test, NCA, anti-phospholipid antibody studies, and they were done like 4 to 5 weeks ago. For thrombocytosis in the range of 500, it was thought to be like as a secondary reaction to iron deficiency versus essential thrombocythemia. Iron studies came back showing mild iron deficiency, and patient is still waiting for JAK2 mutation test. ENA added some more rheumatological studies, ordered ENA, anti-double-stranded antibodies, anti-histone antibodies, and complement level was checked again. So patient with stroke found to have interatrial shunt on echocardiogram. A Doppler study of the lower extremities was ordered, which showed chronic non-occlusive DVT within the left common femoral vein. Apparently, patient did not have any signs of DVT at that time. So it was a discussion between neurology versus our team, whether we should go ahead and start her on heparin or versus keep her on Agrinox and continue the same treatment. So after 72 hours of stroke onset, patient was started on heparin and Agrinox was discontinued. And we followed her labs with DVT, stroke, AKI. Patient came back homogeneous positive for ANA in high titers and normal complement levels. Our differential diagnosis at that time was either vasculitis versus autoimmune pathology. So we consulted Dr. Treadwell. He came by, reviewed patient chart, did HNP, everything from the scratch. And his differential diagnosis was undifferentiated connective tissue disorder, most likely SLE, and patient symptoms most likely were secondary to lupus cerebritis. Other complaints, patient had post-stroke syndrome. There was significant Raynaud's phenomena in the fingers, had CKD, AKI on top of that, had chronic anemia, cardiomyopathy, pulmonary hypertension. So he was quite sure that it's probably autoimmune. Patient was started on 1 gram of IV solomedrol, and then she's currently getting 15 milligram of prednisolone, and then we started her on Imuron. So this is the EKG from 2 days ago. Overnight, nurses noticed that there is a change in the rhythm. So we got a 12-lead EKG, and this was the rhythm. Basically, it's a neurocomplex tachycardia at heart rate of around 150 to 160. Irregular, can't see any definitive P wave. So this was a short run of atrial fibrillation on the patient. Patient was started on metoprolol, and she reverted back to normal sinus rhythm within a few hours. And heparin drip was switched to Eliquis yesterday. For interatrial shunt, cardiology team was consulted regarding the indication of closure. And they were like, if patient is going to be on long-term anticoagulation, probably there's no benefit of doing the closure. But if she continues to have recurrent strokes, or if she does any contraindication for chronic long-term anticoagulation, we can consider closure, but she probably going to need TEE before that. So our patient is still with us. We are following up with Dr. Treadwell and waiting for further recommendations. So far, that's the update. I'm going to give it to Umar.
Good morning, everyone. We're going to go now over the investigations that we got
But before that, we conducted a more specific kind of physical examination. I just want to show you the findings. So since autoimmune diseases are on the table, we went to examine the joints and the skin for any findings. Actually, there weren't many, but some of the things, like she had some swelling of her ankle joints, and she did complain of some pain in her ankles in the past. And we examined the mouth. Does anybody know why we went and examined the mouth? So in some forms of systemic sclerosis or CRIST syndrome, there could be thinning of the lips and some furrowing around the mouth, and the opening of the mouth would be limited. Not much of that was appreciated on her mouth examination. We went specifically and examined her fingers. There was some slight thickening, but and like a minimal kind of tapering towards the end, like concerning for sclerodactyly, but nothing too concerning. Also, she always had low finger stick blood glucose, and whenever we got her PMP, the glucose was normal. Anybody has any idea about this? Her glucose on the finger stick was always low, but like on the PMP, the glucose was normal. Yes, exactly. So she did have Raynaud's phenomena. She used to complain of cold fingers always and some discoloration sometimes. So this is very important. Sometimes there could be some instances where the capillary blood glucose is different than the plasma blood glucose. And one of them is when you have poor circulation to the fingertip. So after this, and you can see that her fingers are not that shiny, because like in sclerodactyly, what happens is usually we have some folds and ridges of the skin, and when light comes, it scatters through these ridges. But like in sclerodactyly, when you have all of that sclerosis, the skin actually becomes flat, and this allows it to reflect back and become shiny. Let's go next. So, these tests were driven by the nephrology doctors. They wanted to work up the TMA, or the thrombotic microangiopathy. The main differential diagnosis was TTP versus atypical HUS from the Plavix that she took. So we measured the ADAM-TS13 activity. It was a little bit decreased, but not to the extent where it's diagnostic for TTP, where it will start messing up with the von Willebrand multimeres. For the atypical HUS genetical panel, it's still pending. It's a very kind of specific test. So until now, we don't have any news on that. Let's go next. Yeah. So pretty much, this is the workup that was done outside. They did not find anything significant in terms of the anti-ANA or lupus workup. Lupus anticoagulant workup was negative. SPEP was negative. Her ANCA panel was negative. Complements were normal, and some of the CRIST and scleroderma workup was also negative. So this is the SPEP they got, nothing significant. Next. So this is the workup that we got. Interestingly, her ANA turned positive, and it's homogeneous, which is seen in SLE or drug-induced lupus. Her anti-DNA was equivocal, and for the antihistones, actually they were moderately positive. And this was like the only pertinent finding that we found. The RBCs were coated with IgGs. And other than this, all of the scleroderma workup was negative, and the mixed connective tissue disease workup was negative. And still we have plenty of tests pending, especially like the antiphospholipid, but like it was negative on her previous testing. We got the factors, no major abnormalities with the clotting factors. Next. So this is a nice slide which shows you like what are the causes of falsely decreased finger stick versus like the plasma glucose. Basically anything that impedes the flow to the distal extremities. Okay, and now I'm gonna leave the mic for Gianna. Thank you.
Okay, so we're gonna talk about drug-induced lupus a little bit.
So drug-induced lupus, you have drug exposure that leads to SLE-like clinical features, and this is an example of an environmental trigger leading to the development of lupus in a genetically susceptible person. It's about 6 to 12% of all lupus cases, and in the US, we have about 15 to 30,000 cases per year. Male and female have about equal chance of getting it. It's more common in older people, with one exception, and more common in whites. It depends on the drug cause. Usually it's, which I'll get to it later, it's drugs for older people, but minocycline, usually it's young white females that use it for their acne. Hydralazine is the first drug to be associated with lupus-like symptoms. And then labs, you can normally see, you can have ANA positive. Sometimes you can have ANCA positive with certain agents. Antihistone antibody is the most strongly associated one that you'll have with this. And anti-double-stranded DNA is usually not positive. So there's over 100 drugs, I think, that are found to be associated with drug-induced lupus. These are the definite ones. So perkinamide is the most common. You have about 15 to 20% of people taking it can have drug-induced lupus. Hydralazine, those are the highest. And penicillamine, your anti-TNF alpha, most common being infliximab and etanercept. Minocycline, like I talked about, isoniazid, rifampin, some of your seizure meds, PTU. There's some probable associations, beta blockers, captopril, which Our Lady was on at some point, HCTZ, amio, and then possible or penicillin, tetracycline. So a lot of drugs that we use pretty commonly. So these are some clinical features in drug-induced lupus. Like I said before, males and females have an equal risk. Symptom onset is usually abrupt. Most people have a mixture of fever, malaise, arthralgias, or arthritis. And then you can have more severe symptoms like pleuritis or pleural effusions or pulmonary infiltrates, and those are usually seen with perkinamide. You don't usually have renal involvement with this, and usually it's older white individuals. So what's the pathophysiology? So the pathophysiology is not really clear, but there's a bunch of different mechanisms that are thought to be responsible for inducing autoimmunity in these people. And sometimes there's different, depending on the drug, there's a different reason to why it's causing drug-induced lupus. So there are some inherited differences in drug metabolism, such as your acetylator status and immunogenetic characteristics that are genetic factors that can influence your risk of developing drug-induced lupus. And then some of your potential mechanisms for drug-induced lupus are abnormalities in your oxidative drug metabolism, drugs acting as agonists for drug-specific T cells, cytotoxic drug metabolites, interference with cytotoxic T cell antigens, or programmed cell death receptor 1 immune checkpoint molecules. And then some genetic risk factors, your HLA-DR4, HLA-DR0301, and this complement for null allele. So how do you manage drug-induced lupus? Obviously, stop the drug that's causing the drug-induced lupus. Symptoms will usually resolve in a few weeks, but can last several months. For people who have mild cases, fever, arthralgias, you can do NSAIDs or low-dose steroids. You can do hydroxychloroquine temporarily if they have mild to moderate symptoms that are not clearing within 4 to 8 weeks. And then rarely do you need to use steroids, but you can use high-dose steroids for more serious manifestations like pericarditis. And then you do not want to re-challenge the patient with the offending drug, but there's not really any randomized clinical trials that give us a good treatment approach.
Hello, everyone. I'm Alex. I'm a medical student. So we're going to go through a board-style question. Go ahead and read this. This is from our faithful UWorld. We'll kind of discuss it after we take a second to read. So what are we thinking here? It's a long one. Just shout it out.
excellent work. And this is kind of the objective discussing what we were trying to get from that question. And a dog.
What's up, Max?
How was her RVSP so high? Did you get, like, what was on the chest x-ray or CT?
So multi-system involvement. Dr. Treadwell thinks that the pulmonary hypertension is most likely because of her, mysterious rheumatological disease. Yeah. I know it's really confusing, but all of her echoes, you know how she was having multiple strokes in like 2019 and earlier 2020. Her echoes at that time, the RVSP was always like 35 to 40. No intraatrial shunt or anything like that. No. So this is what popped up when we did our investigation here. She never had AFib before. All her EKGs from Boyce Willis and from NASH, all of them were normal sinus. What? Yeah.
Couple issues that run amiodarone. I think a lot of this had just been kind of progressively happening over the last few months. Like her kidney function, this was kind of a new onset over the last few months, and as you could see, like that ANA and all the other workup they did, that was in August. Like her creatinine had been steadily worsening, and she was originally seen at the local nephrologist at the Boyce Willis Clinic in Tarboro. They then referred her to ENO when they couldn't get a diagnosis. They convinced her to do a kidney biopsy, which didn't show any signs of connective tissue disease or lupus, and so that's why they kept referring her back between the two nephrologists, because they really didn't know what they had going on. And so when she came here, the nephrologist actually personally called Dr. Lyles and said, hey, we want you to take a look at this patient because we don't exactly know what's going on. Because like all this had kind of been progressive. She had coronary disease with stents last year. And since that time, she had actually done fine. It was over the last few months that she had started losing weight. She became less active. She ended up at NASH with these problems. And so this kind of was a rapidly progressive with an acute onset with this admission. So before this, she was kind of fine. Like she had these TIAs, but really wasn't showing any chronic progression. Like when you talk with her daughters, they all say that she was a normal, completely happy person, did everything for herself, and now she's just kind of lying in bed and just not nearly the same kind of person. And so this was a very quick decline for her.
Yeah, and specifically for drug-induced lupus, the only medication that we could find on her in her history was they had put her on captopril for, I'm assuming, the proteinuria, but that was taken off in September of this year. She was only on captopril for a few months. Yeah, complements are normal. From the workup in August and from the workup we did.
Yeah, but they did a second referral for the kidney biopsy, and they read the biopsy as this is atypical HUS. Like this is what we see on kidney biopsies like that. And so that was that's why they were like struggling with what to do, because they're like, okay, the kidney biopsy says this, and generally like when you're going with these kind of things, like kidney biopsy is ultimately what kind of sets this apart. And so that's why everyone's just kind of like, what is going on?
Also, just fun fact, Plavix is associated with atypical HUS, and that's why she was taken off Plavix, just to let you know.